people can rewatch them if they need to. And folks on Zoom, folks in person, feel free to chime in with questions, comments at any point as I go through these. So scooch my little footpad over here. So we're wrapping up disorders of childhood. I know that's very relevant for 3 of y'all. And so fine motor disability is a symptom of a disease rather than being like its own diagnosis, if that makes sense. And it's an impairment of fine movements. We typically think of the hands, but it can also be the feet. We don't think about our feet as being things that have a lot of fine motor movement. I don't know if y'all have ever seen the diagram of the homunculus. It's basically like a representation of the human body based on like the amount of sensors and receptors we have. And like the hands are huge and the feet are huge. And it's because even though we don't think about it that much, our feet have to navigate a lot of different surfaces every day, right? Steps, on different things. And the vast majority of the time, we don't even notice, we don't fall because our feet just kind of figure out what to do. And it requires integrated complex coordination between numerous neuroanatomical structures, neurons, receptors, things along those lines. Yeah, yep, back to anatomy, yep. And the damage to any of those structures can cause a fine motor disability. So it can be in the brain, it can be in the receptor neurons, it can be in the ones that coordinate the movement within the limb itself. It can be the muscle itself. So there's lots of different things that can cause fine motor disability. There are a lot of symptoms in psychology that we can liken them to like a fever, right? So if someone has a fever, it doesn't mean you know what's wrong with them, right? It could be COVID, it could be the flu, it could be an infection from a cut they got last week, right? So it's just a symptom. Here we go. So if there's a fine motor delay, this is where kiddos are not able to use their hands and fingers to hold, manipulate, and use objects. And this is a really important thing for any sort of developmental thing, anything we're going to diagnose in kids, is that it has to be matched with their developmental age, right? So if a baby can't do this, that's not a fine motor disability, right? If a fine motor delay, if a baby can't write, right, that's fine. But if a kid who's like 10 is still having a hard time holding a pencil, there might be something going on. These require hand-eye coordination. So you have to see something and respond with the right movements in your hands and fingers. And it also could affect speech because there's also fine motor coordination there as well. The lips, the tongue, and the face muscles. There's a lot of intricacies that go into that. And this is why, again, speech problems can be caused by muscle problems, issues of the brain that sections of the brain that coordinate muscle movements, but also the centers for like understanding and producing speech. So you can also have either on its own or combined with this delays in gross motor skills like crawling or walking. Now, there are huge windows that are, sort of normal, right? So this is one of the things I really appreciated. We had like the Mayo Clinic baby book for the first year of our daughter's life. And every single chapter, 1 or 2 pages in, had this big box that was like, kids develop at different times. And it's okay if they're not doing this yet, basically. But it's where, maybe they're, again, like 3 or 4 and they're not walking yet, right? That's concerning. So it's got to be kind of like when we talked about intellectual disability, couple standard deviations away from the mean. And in some cases, this may be associated with something like an autism spectrum disorder or developmental disability. Dyspraxia is where you have problems with movement, coordination, judgment, processing, memory, and there can be other cognitive skills involved as well. So basically what this ends up doing is affecting your ability to plan and process and execute motor tasks. So there are different names. Again, there's actually a sort of a symptom. It could fall under different disorders, motor learning difficulties, perceptual motor dysfunction, and developmental coordination disorder. And so again, this is something you might see at CBA in kiddos, but who also have other diagnoses, right? So some symptoms here can be poor balance and poor posture, fatigue, what we would normally just call clumsiness. You know, I think clumsiness is sort of a weird idea anyway, right? It sort of blames the person for being clumsy when oftentimes there's something like this going on. Can be speech differences, problems in perception, which is going to lead to poor hand-eye coordination. We also know that a lot of the disorders we think of as adult disorders can be seen in kids. So for example, around 2% of kids and 9% of adolescents, so sort of preteens, teens, experience major depressive disorder, which is what we think of when we say depression or clinical depression. And at many as 20%, so 1 in 5 adolescents experience at least one major depressive episode. So that might mean they've had a time where they're depressed, but they're not then. So these are also issues as well, and that's what we're going to go into. And this depression can affect anyone at any age. Again, we can see it in kiddos, we see it in adults, older adults. We have to really sort of screen depression versus other things, because some of the symptoms of depression can look like medical things going on, right? So like if your appetite changes or you're feeling really fatigued, and some of the symptoms of depression can even look like a dementia. And so in older adults, it's really important to screen this out before you just sort of like assume someone has Alzheimer's. So you have to have 5 of these 9 symptoms. Oftentimes, unfortunately, people with severe depression have most, if not all 9. But one of them has to be one of the first 2. So depressed mood most of the day, nearly every day. And in kids, this can manifest as irritability, especially younger kids, kids with social emotional issues. They might not have the words, the language, the vocabulary to say, I'm depressed, even I'm sad, right? So it might just come off in them sort of seeming really irritated at everything. And then the other one, you can have 1 and or 2, is what we call anhedonia. It's a fancy word for saying diminished interest in activities. So stuff that they normally like to do, they just don't want to do anymore, or they say they don't have the energy to do it. To the point, again, that when someone's really severely depressed, they might kind of not do anything. Like their world gets a little smaller. You can have a decrease or an increase in appetite, and this can or cannot be associated with weight gain. In order to be diagnosed with a major depressive episode, you just have to meet criteria for 2 weeks. So you're not going to see a lot of change in weight in that amount of time, right? So this can be similar to what happens to people when they're stressed. So for example, when I'm a little stressed, I will stress eat, right? I will just like eat all the snacks in the house, things like that. But when I get really stressed, I can't eat. The week before I found out whether or not I matched for my internship, I was barely eating because I was so stressed and like my stomach was acting up, and it was fine. But in my mind, I was just so anxious, I had a hard time eating. And so it can go in either direction. Similarly, you can have insomnia, where you have a hard time falling asleep, staying asleep, or you'll wake up too early and not be able to get back to sleep. Or hypersomnia, and hypersomnia is you just sleep all the time and you often wake up still feeling tired. And again, I talked about this for older adults, but even in want to say like normal age, younger adults, I guess, we have to kind of rule out medical things here, right? So for example, I knew someone in college who had hypersomnia, really thought, because it was much more of a thing when I was in college, that they had mono, because mono was like going around, tested negative for it, and their doctor was like, would you be depressed? And it was like full light bulb moment, right? Psychomotor agitation. This is like being on edge, kind of fidgety. Granted, I only saw clients for 5 years, but I personally never saw someone who was depressed with the psychomotor agitation. Certainly people who are anxious. But what you tend to see is psychomotor slowing, psychomotor retardation. So they talk more slowly than usual. Everything feels like it's really a big effort to talk, to move, to do basic tasks. Fatigue or loss of energy. And then you get into the ones that start to get scarier. Feelings of worthlessness or guilt. They'll blame themselves for things that clearly are not their fault. And then diminished ability to think or indecisiveness. Again, this is where it starts to look sometimes like, is this a neurocognitive disorder? Is there some sort of dementia going on? And in fact, sometimes symptom 8 is called pseudo dementia. And then 9, recurrent thoughts of death, suicidal ideation, or suicide attempt, or having like a specific plan. And that's the one, obviously, that you take the most heed to. And we want to obviously be supporting this person, but if they're reporting suicidal ideation or plan, you need to address right away whether that person is safe or needs additional support, perhaps inpatient. All right, so with mood disorders, major depressive disorder, we have the major depressive episodes. What we used to call manic depression, now called bipolar disorder. You have depressive episodes, but then you also have episodes of mania or manic episodes. And this is elevated, expansive, or irritable mood and increased goal-directed activity. So these people, and this is tough because especially like in kids, but certainly in adults with an ADHD diagnosis as well, it can be hard to like parse this apart from like the hyperactivity of that. And it's got to last at least 1 week. Although there is an exception that if it's so disruptive to your life that you have to be hospitalized, it doesn't matter how long your manic episode's been going on, it's a manic episode. You can diagnose at 3, 4, whatever, how many days. And you've got to have 3 or more of these symptoms. Grandiosity, they think they're really important. They think nothing can hurt them. Well, that's obviously going to play into their impulsivity as well. They feel like they do not need to sleep. I said this to my adult psychopathology class last week. It's sort of like this friend I had in college week. I had a friend in college who was bipolar, and when she was in a manic episode, she would just like stay up all night on eBay and like not seem tired the next day. It was very strange. They become more talkative than usual. Their thoughts have this feeling of racing, like they can't keep up with them. They tend to be pretty distractible, have a hard time like maintaining focus on one task. Increase in that goal-directed activity, psychomotor agitation, and then activities that have the potential for painful consequences. So this can include things like spending all your money, like drinking and driving, like engaging in sexual activity without adequate protection, because again, you feel like you're not going to be harmed by it. There's also what's called a hypomanic episode. All the same symptoms, but sort of lower grade, lower severity. Has to last 4 days. Not severe enough to be hospitalized. As soon as you're hospitalized, it is diagnosed as a manic episode. But it's associated with this unequivocal change in functioning, and that others can observe the change. So the reason they created hypomanic episodes is to sort of mark that there is a distinction. For some people, they never get the full mania. That's a little bit more dangerous, more severe, but it still obviously is disrupting their lives. So these are the types of mood disorders, and we're going to go over each one. And mood disorders are the most commonly diagnosed. I want to say something like 16% of people will be diagnosed with a depressive disorder specifically in their lifetime. Lower for men, higher for women. All right, so these are the different disorders, and they're really just marked by, I'm gonna put the lights in for a second, that's where we put the lights on. They're really marked by the type of mood episode you experience. So if we just look at depressive episodes, so if we've got someone who's having the types of depressive episodes we just walked through the symptoms for, then we're going to be diagnosing them with major depressive disorder. Some books and older texts will refer to this as unipolar depression. There are also people who have this like chronic milder depression. They would never really meet criteria for a depressive episode, but they're just always sort of feeling crummy and it's interfering with their lives. It's been going on for a long time. That's called persistent depressive disorder. And then those are if you don't have any kind of manic episodes. Now, if you're having depressive episodes with full manic episodes, those ones that are 7 days and or you're being hospitalized, that's bipolar 1 disorder. And basically, as soon as you have a full manic episode, you can be diagnosed with bipolar 1. The assumption is you will eventually have a depressive episode. If you are having full depressive episodes with hypomanic, those less severe manic episodes, then you're diagnosed bipolar 2. So that's the distinction there, is the type of manic episodes you have. Now, if you have sort of persistent depressive disorder, that chronic milder depression, but you occasionally have hypomanic episodes, then that's called cyclothymic. So of those, major depressive disorder is certainly something you run into the most often. So for major depressive disorder, you need to have at least one major depressive episode. Unfortunately, a lot of people have multiple throughout their lives. Never had a manic or hypomanic episode. As soon as you do, you're diagnosed with one of those bipolar spectrum disorders. And then you have to have significant distress or impairment. This is interfering with your life. This is getting in the way of your day-to-day work. And then for bipolar disorder, as I mentioned, a full manic episode, and then you might also have hypomanic episodes. You might also have depressive episodes, and they can be before, they can be after that full manic episode. Bipolar 2, you've got hypomanic episodes, you've got depressive episodes, never had a manic. So basically, it's like if you ever have a manic episode, you're diagnosed bipolar 1, you've had a depressive episode with no other mood episodes, you're diagnosed with major depressive disorder, and then sort of the catch-all for the less severe manic, but also having depressive episodes is bipolar 2. Alrighty, so the next thing we're going to talk about is anxiety disorders. And again, these are something that can affect people at any stage of their life. We certainly see very specific anxiety disorders in kiddos, sort of average adults certainly struggle with these quite a bit. And then we see them in older adults as well. And so I think the one that's most commonly diagnosed, but least commonly talked about sort of outside of the psychological world is generalized anxiety disorder, or GAD. So this is people who just worry all the time. When I was seeing clients, if someone said to me, I've always been a worrier, then in my mind, I would be like, okay, we need to be keeping generalized anxiety disorder in our back pocket as something to look at. So they just worry about everything and anything. They'll spend a lot of time just thinking over and over, worrying over and over. Their symptoms are restlessness and fatigue, trouble concentrating. Sometimes they worry so much and they're so tense, they'll actually get like muscle fatigue or muscle tension. And then sleep problems here, we definitely tend to see more insomnia. Their worries keeping them awake at night. In order to be diagnosed, you have to have had symptoms for at least 6 months. That's just to show it's not situational, because you don't want to diagnose someone who's showing these symptoms, but it's because they're about to take the MCAT or something, right? But certainly there are other diagnoses you can use if the person needs help before that. It's pretty common in Western society. Usually first appears as a kiddo or during adolescence. Again, I've always been a worrier. But only about a quarter of people with GAD come in for treatment. Bunch of different reasons for that. Obviously, access is always a struggle. But also, unfortunately, the pathology can keep these people away. They worry so much about therapy and like, is that other person going to judge me? And maybe I don't need therapy, but maybe I do, right? That it can keep them away. Alrighty, so specific phobias, I think, are what we tend to think of when we think of anxiety disorders. So these are marked, persistent, and disproportionate fears of specific objects or situations. Similar to GAD, we're looking at 6 months or more. For a lot of folks, these are lifelong, right? These are things like fear of snakes, fear of heights, things along those lines. And depending on your situation, right, these can be more or less problematic. You live in the middle of New York City and you have a snake phobia, you can probably function in your day-to-day life, right? You're probably not going to run into them. You live in the middle of New York City, particularly Manhattan, and you have a phobia of riding in elevators, you're going to build up your quads a lot, right? Going down all those steps. And everything will take you more time, basically. Yeah, I had an elementary school teacher who was just terrified of snakes. And I remember one time she was like looking through a National Geographic and there was a picture of a snake and she literally like chucked it across the room. Like luckily none of us were in that corner. We were allowed to do that, right? But it was just like a gut reaction. She didn't think, it just happened, right? So this can, affect you in weird ways like that. So they're going to experience fear and anxiety immediately when they're exposed to whatever they're afraid of. They're going to avoid anything related to the feared situation. So like maybe that elementary school teacher just wouldn't go through National Geographic anymore after that. People with like a heights or elevators fear, right, might avoid working in a building that they would need to be involved in that. They certainly wouldn't be the people to like, go to the top of the CN Tower in Toronto or things along those lines. And they're going to have significant distress or impairment. Again, if you live on a farm and you have a fear of elevators, probably going to be okay. Probably not going to have significant distress or impairment, right? But again, if you're working on the 32nd floor of a building, maybe more problematic. So the most commons are those phobias of specific animals or insects, arachnophobia, things along those lines. Heights. I didn't mention claustrophobia. That's a really common one. Fear of enclosed spaces. Thunderstorms or other loud noises. And then there's sort of a subcategory called blood injection injury. And this can get really problematic because people with that phobia will avoid going to the doctor, right? And so then they're not getting the preventative screenings. They're not getting medical assistance when they need it. I actually knew someone in grad school who she and her supervisor had devised a really cool treatment for a client with blood injection injury phobia. They actually would have her go to the health center on campus and get just blood drawn. Not a ton, right? Just like one vial. But doing so, she was able to overcome her phobia. All right, agoraphobia. This translates literally to fear of the marketplace, but it's really more fear of being in public places and situations. And in particular, you have this marked, disproportionate, and immediate fear of being in these public situations. So sometimes it's very specific, like public transit, open spaces like parking lots, being in crowded shops, theaters, cinemas, being in a line, a queue, or in big crowds, or even like some people with really severe agoraphobia, it gets to the point where they feel like they can't leave their house. They feel like their house is their only safe place. And so just being outside of their house becomes problematic. And these fears are often related to the concern that if something happened and they needed to get away, they couldn't. Or they think like it'd be hard to get help. And then they avoid everything. And again, that can make their world smaller and smaller. Symptoms have to last 6 or more months typically, and then you have the significant distress or impairment. And this typically develops in your 20s or 30s. And sometimes this like goes along with panic disorder. So for people who have panic attacks, it can feel like you're having a heart attack. It can be really scary. And people around you will like pay attention to what's happening, right? Because if you think someone's having a heart attack, you'll try to get them help. And so like that becomes part of the fear. This is also common in people with things like Crohn's disease, where they can't control their bowels all the time, or epilepsy, where they're afraid they'll have a seizure in public and not be able to get help or get away. So this can be related to other psychological or medical conditions as well. Social anxiety disorder used to be called social phobia. I kind of like this a little better because the anxiety feels a little different than phobia to me. So marked disproportionate and persistent fear or anxiety about one or more social situations where they're exposed to possible scrutiny by others. And again, 6 months or more typically. So it's really about fear of negative evaluation by other people or being offensive to others in some way. And every time they're in a social situation, they get anxious and they'll start to avoid those social situations, which again, can make your world smaller, at least socially, right? And then they'll have significant distress or impairment. And it can be really narrow. So for some people, their social anxiety disorder is limited to public speaking, right? For folks like that, we're actually able to do behavioral techniques and or psychiatrists can prescribe them a fast acting anxiolytic. They can take it the day they have to give their speech, able to get up there, no issue. But for some people, they're worried more generally about their own social ability, other people judging them, things along those lines. And people with this disorder tend to think they're just failing all the time, when in fact, if you objectively rate them on like their public speaking ability, their social skills, they're actually doing fine. All right, so panic attacks. A lot of adults will have a panic attack in their lives. It does not mean you have panic disorder. Panic disorder is repeated panic attacks. So as I just mentioned, these can be really scary. They are abrupt surges in intense fear and or discomfort. They tend to peak very quickly within a couple of minutes. They also generally tend to subside fairly quickly, like within 10 or so minutes. But as we look at these symptoms, you'll see why people might think they're having a heart attack. Their heart will pound, they'll sweat, they'll shake, they'll feel like they can't breathe, like there's a shortness of breath. They'll feel a choking sensation or chest pain. Again, these sound like heart attack symptoms, right? Nausea, dizziness, Those are actually heart attack symptoms that we see more often in women. Chills or heat sensations, paresthesias are like feelings of numbing or tingling in your limbs. Derealization is a sense of feeling detached from the world around you. Depersonalization is a feeling of like being detached from yourself or kind of watching yourself or outside your own body. They feel like they're losing control or going crazy, or they might feel they're dying. And so what happens physiologically in a panic attack is it's actually an overaction and overreaction of your fight or flight instinct. So it's telling you, let's get out of here. There's a bear, basically, when you're in a situation there's not actually a bear or anything actually scary, but it overreacts. And so all the things like changes in breathing, changes in your heart, things along those lines are actually things that happen to your circulatory system to help you fight or flight if you need to. So it tends to get you to breathe faster to get more oxygen going throughout your bloodstream. It tends to divert the blood more to your legs. Our legs tend to be more powerful, right? And then we can, in theory, like kick someone or run away. The nausea is because it actually stops digestion. It's sort of like we can digest stuff later. Dizziness and the derealization and depersonalization is because blood flow isn't stopped to your brain, but your brain is actually given less priority for blood flow in these minutes because your body doesn't want you overthinking. Your body just wants you reacting. Same thing for like the tingling. It's because the blood's being re-diverted to your major muscle groups. And then obviously just sort of our own reaction to this can make us feel like we're going crazy or dying. Now, I was not an anxiety specialist, so I only ever treated 2 people who had panic disorder. But all the stuff I just told you all is part of the therapy for it. You do what's called psychoeducation, and you teach people what's happening when they experience a panic attack. And for those 2 people I saw who had less severe panic disorder, only occasional panic attacks, just that psychoeducation was almost like a magic cure. As soon as they knew what was happening, when they started to have another one, they were able to tell themselves, this is just my body overreacting, and they didn't escalate. So that was really cool to see. I also had a friend who did specialize in anxiety disorders, and she said for people with more severe anxiety disorder, where they're having these more often, it wasn't as helpful. So in order to be diagnosed with panic disorder, you have to have recurrent panic attacks. And then you've got to have worry about having another panic attack and or changing in your behavior so that you don't have a panic attack. So people with panic disorder will avoid engaging in anything that will get their heart rate up, get their blood flowing, get them breathing heavy. So they won't exercise, they won't have sex. They'll avoid other things that make them feel that way. And so one of the treatments for panic disorder is actually to do things in the office to get that going. And then you teach them how to cope with it. You give them relaxation exercises to engage in, you give them meditation, things like that. So for example, you might have someone like spin around in a chair or breathe through a straw. And you're right there the whole time, so they realize they're okay. All right, so really interestingly, OCD, obsessive compulsive disorder, used to be classified with the anxiety disorders. But in 2013, when they brought out the 5th version of the DSM, they made obsessive compulsive and related disorders their own category, sort of recognizing there's more than just anxiety as part of the symptoms. So we've got the obsessions. These are persistent thoughts, ideas, impulses, or images that feel like they're kind of like injected into your consciousness from elsewhere. Not to the point of being psychotic, but just sort of feeling like these kind of come out of nowhere. They invade your consciousness. And then compulsions are repetitive and rigid behaviors or mental acts that people do to sort of appease the obsessions, to keep the anxiety related to the obsessions at bay. But typically these are only temporary, and so that's why people do them repeatedly. So we diagnose people with this when the symptoms feel excessive or unreasonable, when the symptoms are causing distress in our folks, when the symptoms take up a lot of time during their day. It can take hours performing these rituals, and they're interfering with daily functions. So you've got to have recurrent obsessions, compulsions, or both. Typically people have both. And the obsessions and or compulsions are time consuming and cause that distress or impairment we've been mentioning. And then another category of disorders that used to be under the anxiety disorders, but are now their own category, is the stress and trauma related disorders. And so when someone experiences a traumatic event, and this can be anything traumatic, like for a long time, people only thought of war, right? Only thought of being in the battlefield. Then in the 70s, we started recognizing like, oh, people who have been sexually abused, sexually assaulted, physically abused have similar symptoms. And since we've expanded to realize like people that in car accidents or plane accidents, right? Things along those lines can also experience these symptoms. And so once you've experienced a traumatic event, you can start to have symptoms right away. If you start to have symptoms right away, it's called acute stress disorder. And then 4 weeks of the event, it lasts longer than a month. So for some people, they have these extreme symptoms for that month, and then those symptoms go away. For other folks, those symptoms then keep going, in which case we diagnose them with PTSD. And the reason we have these two different disorders is because we don't want to like over pathologize someone who's going to have symptoms for a short amount of time. Now with PTSD, your symptoms can begin anytime after the traumatic event. So it can be a month after, or in the case of when I was at the VA, we were seeing, this was 2009, 2010, and we were seeing Vietnam vets from the 60s and 70s coming in for treatment for PTSD for this first time. And some of these folks had been essentially self-medicating with alcohol. And then when they got clean from alcohol, the nightmares, the flashbacks, all of that came. So, yeah.
For PTSD, the symptoms like not show right away, like they don't feel it right away.
Exactly.
They start like
Exactly. Yep. Yeah, and in fact, like when we look at PTSD, like neurologically, like the brain tries to protect us. The brain essentially tries to make us forget what happened. But obviously there's still this awareness. So yeah, they can like not even remember per se, or like not let themselves think about it, but like you said, still be self-medicating for sure. Yeah, good point. There's a lot of denial with PTSD a lot of times, unfortunately. Alrighty, so you have to have exposure to a trauma, actual or threatened death, serious injury, or sexual violation. Also, they added to the 5th edition of the DSM that if your job requires you to essentially view these things as media, that can also count. So for example, I had a Navy vet, or was he a Marine? I think he was a Navy vet while I was at the VA, that his job in Afghanistan and Iraq had been to sit in a tent every day and just watch closed circuit footage from everybody's helmet cams of marketplace disasters, of raids, of things like that. And so he had PTSD even though he hadn't been in that situation, because he had to stare at it every day for his job. And then you've got to have at least one intrusive symptom. Often they have several. So recurrent involuntary and distressing memories. They feel like they just sort of pop up out of nowhere. Nightmares, distressing dreams. Flashbacks is sort of the hallmark that people think of. So when you have a flashback, you really feel like you're back in the situation, the traumatic situation. So I had vets tell me about like having a flashback when they were driving and starting to drive down the middle of the road, like over the double yellow line. Because that's what they would have to do in country to avoid the improvised explosive devices, which were often on the side of the road. That's great if you're on an open empty road. It's not great if there's traffic coming the other way, right? Other things, people have been sexually assaulted during a consensual sexual event, perhaps even with their partner or their spouse, their married person, have a flashback and feel like they're getting sexually assaulted again. They'll have significant distress and exposure to anything that reminds them of the events. So I had a vet who had out processed from the army, but still worked for them civil service. And he left the room anytime anyone mentioned Iraq or Afghanistan. When you're working at an army base, that's nearly impossible, right? He was leaving a lot. And then they'll have physiological reactions. Their reactions can essentially look like a panic attack. And then they'll avoid stimuli associated with the events. So avoid where it happened, avoid people who remind them of the events, which sometimes means cutting yourself off from your support network, right? If it was like your best friends in the service who were with you when something happened. And then they'll have negative changes in cognitions and moods. So trouble remembering what happened. And again, your brain does that on purpose. This is one I saw a lot. Exaggerated negative beliefs about yourself, believing you were somehow to blame, because you're a bad person, this happened to you. And negative emotions. And changes in arousal and activity. Hypervigilance is always being on your guard. And you'll see this even when people who don't have PTSD, who are like military or former military, law enforcement, when they come into a restaurant, say, they'll try to sit in the corner so no one could sneak up on them and they can kind of watch everybody. I had a vet who had a really common injury in addition to like traumatic brain injury is like knee and back problems because they'd be carrying around 100 pounds of gear with them every day. And so this guy had really bad knees. And he had a property that was several acres, but part of his hypervigilance is he would patrol that property every night. So obviously it was exacerbating his knee problems. Let's see, we got something in the chat. Yes, their behavior can totally change in social situations. Hannah, you're spot on. Where sometimes they'll start avoiding them or they'll like only sit in the corner, not really talk to people. Yeah. We'll also have an exaggerated startle response. So if you are able to sneak up on them, you can unintentionally, they'll jump a mile. A friend of mine on my internship saw a vet who one day his kiddo woke him up. He didn't know it was his kid. He didn't know where he was. And he actually grabbed his kid by the throat because he thought it was an enemy combatant. He didn't hurt his kid. It was fine. Kid was obviously scared and they had to like talk about like, you can't wake daddy up, right? Get mommy to help, that type of thing. Yeah. And it can be about helping them feel as comfortable as possible. And Hannah, that's going to be individual for everybody. Just sort of figuring out what works best for everybody else. They'll also have sleep disturbances, insomnia, nightmares, I mentioned before, and then significant distress or impairment, and it lasts longer than a month. Yeah, so like anyone with any disorder, a lot of this comes down to figuring out what helps them individually, right? It's going to be different depending on your trauma itself, right? So if you were in a motor vehicle accident, you might need help like working back into just sitting in a car, much less driving in it. And just one thing I'll say that's really cool, that they've actually started to do for people with PTSD, in particular combat veterans, is they can use VR to sort of recreate the traumatic situation and help them learn to sit with that memory and then not to have control over them. Really interesting. All righty. Let me look just real quick at where we are in the slides, how many slides I got. I had more than I thought. But I really do want to stop here just because the neurocognitive disorders I like to talk about them all together. Plus, last time I kept you the whole time and I like to give you a little extra time whenever you can. Next week we'll pick up with neurocognitive disorders. And there's some stuff that y'all aren't really running into, so we might not spend as much time on it. But yeah, so people who gave me your contracts last week, I didn't get a chance to scan them yet. Yes, the slides are on Blackboard, so you can find them there. And then this recording will be on Blackboard as well as soon as I get it uploaded.